Welcome to the deep dive. Today we're tackling a really important area for those of you heading into nursing, personality disorders.
Yeah, definitely key.
We've got quite a bit of information here, and our goal really is to pull out the essential stuff you'll need for your practice.
Exactly. Make it clear, practical.
And focus on what you'll actually see and need to do.
Consider this your go-to for understanding these, well, complex patterns. We want to go beyond just definitions and really connect it to providing nursing care.
Okay, so maybe let's start at the beginning. What actually is a personality?
Good place to start. So personality is basically the consistent way someone thinks, feels, perceives, and interacts with the world and themselves.
And these patterns form pretty early on, right? And tend to stay quite stable.
That's right. And those specific, consistent ways of responding, we call those personality traits.
Hey.
Now, where it gets significant for healthcare, and especially for you nurses, is when these traits become really rigid,
Yeah.
inflexible.
To the point they cause problems.
Exactly. They cause distress, or they impair someone's ability to function, maybe in relationships, at work, just important areas of life.
Yeah.
That's when we start talking about personality disorders.
And these disorders affect specific areas.
Yeah, the notes highlight 4 key areas. Cognition, how people think about themselves and others. Affectivity, their emotional experience and expression. Interpersonal functioning, how they relate to people. And impulse control.
Right. Impulse control.
Yeah, managing those urges.
It's fascinating how long we've been trying to understand this stuff. Hippocrates and his humors.
Way back. And then the 19th century had moral insanity, which sounds quite dated now, but it shows the historical effort.
Yeah. And now we use the DSM-5 classification.
Clusters, right.
Yep, 3 main clusters grouped by shared characteristics. Cluster A is often seen as the odd or eccentric group.
That includes paranoid, schizoid, and schizotypal.
Correct. Then you have cluster B.
The dramatic, emotional, or erratic cluster. That's antisocial, borderline, histrionic, and narcissistic. And finally, cluster C, which is more about anxious or fearful patterns.
Avoidant, dependent, and obsessive-compulsive personality disorder.
And that last one, OCPD, it's really crucial for you students to get the distinction. It's not the same as OCD, obsessive-compulsive disorder.
Right. OCD has those specific obsessions and compulsions, whereas OCPD is more about a pervasive pattern of perfectionism and control.
Exactly. It's a personality style, not necessarily driven by the same kind of anxiety loop as OCD. Big difference in practice.
Okay. What really stands out looking at the overview is that even across these different clusters, there seem to be common threads, like interpersonal problems seem really common.
Hugely common. Something like 41% cited in the notes. It really impacts relationships.
Mm-hmm.
And you also see cognitive dysfunction problems with thinking patterns in about 30%.
And emotional instability, affective issues.
Yeah, around 18%, and then impulse control issues make up about 6% across the board. These numbers really show how pervasive the impact can be.
And thinking about how these develop, theories from Sullivan, Erickson, Mahler, they all point to early life experiences and relationships, don't they?
Absolutely. Sullivan's focus on interpersonal stuff and anxiety, Erickson's stages like trust versus mistrust, Mahler's ideas about separating from caregivers, disruptions there can definitely contribute to these maladaptive traits later on.
So the goal today, especially for you nursing students listening, is to build that solid foundation, give you the knowledge that's, well, most relevant when you're providing care.
Let's do it.
Okay, maybe we can start by looking closer at the clusters. Cluster A first, the odd, eccentric group.
Sure. Let's start with paranoid personality disorder. The core feature here is his pervasive distrust and suspicion of other people.
So they assume others have bad intentions.
Pretty much, yeah, even without any evidence. So in a healthcare setting, think about it. A patient might be really suspicious of the nursing staff, maybe reluctant to share health info.
Questioning treatments constantly.
Exactly. It can make building that therapeutic relationship, that trust, really challenging.
I can see that. Then there's schizoid. What's the key thing there?
Schizoid is mainly about detachment, a real detachment from social relationships, and a limited range of emotional expression. They often don't seem to want close relationships.
So they might seem indifferent to praise or criticism.
Yeah, often they can come across that way. In terms of nursing interaction, you might find they don't engage much in conversation, don't seek emotional support, maybe seem a bit aloof.
And it's important not to take that personally, right? It's part of the disorder.
Precisely. It's
Yeah.
not necessarily them being difficult, it's their fundamental style. Respecting their need for space is key.
Okay. And the third one in cluster A, schizotypal.
Schizotypal is more about eccentric behavior, odd beliefs, maybe magical thinking, and significant social anxiety.
But the anxiety is different, more paranoid.
Often, yes.
Is that?
It might stem more from suspiciousness rather than just fearing negative judgment, like you see elsewhere. Clinically, you might notice peculiar speech, odd ideas, maybe just marked discomfort in social settings.
So again, patience and a non-judgmental approach seem crucial.
Definitely. Clear, straightforward communication helps build trust.
Okay, let's shift gears to cluster B, the dramatic, emotional, erratic group. These often seem like the ones that present more outward challenges for staff.
They certainly can. First up is antisocial personality disorder.
Right. What's the absolute core thing nursing students need to grasp here?
The pervasive pattern of disregarding and violating the rights of others. Think deceitfulness, impulsivity, irritability, aggression.
And a lack of remorse.
Often, yes, a real lack of remorse.
Yeah.
It's also worth noting the sources mention higher rates in prison populations and a strong link with substance use disorders.
Okay, this feels really critical for nursing care. What are the key principles?
Boundaries. Clear, firm, consistently enforced boundaries are absolutely number one.
Okay.
And promoting accountability for their actions. You might encounter manipulation, so a firm, matter-of-fact, but still respectful approach is usually best.
So focus on the health issue at hand. Don't get pulled into games.
Exactly. Avoid power struggles.
Got it. Next, in Cluster B, borderline personality disorder, BPD, often talked about.
And for good reason. It presents significant challenges. The core is profound instability in relationships, self-image, emotions.
And you often see self-harm, impulsivity.
Yes, frequently. Patterns of self-harming behavior, impulsivity in things like spending, substance use, maybe risky sex, and a really intense fear of abandonment.
That fear drives a lot, doesn't it? Frantic efforts to avoid being left alone.
It really can. And our notes mention splitting. That's a concept that's vital to understand with BPD.
Can you break that down? What is splitting and why does it matter for nursing?
Sure. Splitting is basically black and white thinking. It's a defense mechanism where people are seen as either all good or all bad. No gray areas.
So perceptions can shift really fast,
Right.
idealizing someone one minute, devaluing them the next.
Exactly. And in a healthcare team, this can cause real problems. A patient might praise one nurse to the skies and then harshly criticize another.
Pitting staff against each other?
Potentially, yes. That's why consistency among all staff members is so crucial. A structured environment, what we call a therapeutic milieu, helps provide stability.
That makes a lot of sense. Okay, next. Histrionic personality disorder.
Histrionic is characterized by excessive emotionality and a constant need to be the center of attention.
So, dramatic, maybe attention-seeking behaviors?
Often, yes. Exaggerated emotions. Relationships might seem intense, but often lack real depth. They can also be easily influenced by others.
And might present with vague physical complaints in healthcare settings.
That can happen, yeah, as a way to gain attention.
Okay. And the last one in Cluster B, narcissistic personality disorder.
Right. Key features here: grandiosity, a deep need for admiration, and a significant lack of empathy.
But underneath the arrogance, fragile self-esteem.
Often, yes. It's a bit of a paradox. They might seem entitled or arrogant, but they can be incredibly sensitive to criticism, even if they don't show it.
So in healthcare, they might demand special treatment, get angry easily if they feel slighted.
That's a common presentation, yes.
Yeah. Okay, let's move into the final cluster. Cluster C, the anxious, fearful group, starting with avoidant personality disorder.
Avoidant. The key here is social inhibition and hypersensitivity to criticism or rejection.
But unlike schizoid, they do want relationships.
Yes, that's a crucial distinction. They often strongly desire connection, but avoid it because they're terrified of being rejected or disapproved of.
That fear must really limit their lives.
It absolutely can, socially, occupationally. They might avoid any situation where they feel they could be judged negatively.
Okay. Then we have dependent personality disorder.
Dependent is about an overwhelming need to be taken care of. This leads to clingy, submissive behavior.
Difficulty making decisions on their own. Fear of being alone.
Exactly. They struggle with independence and often seek excessive reassurance. In healthcare, they might have trouble disagreeing with you, even if it's important for their care.
Right. And finally, in Cluster C, we have obsessive-compulsive personality disorder, OCPD. Let's hit that distinction again.
Yes, absolutely critical. OCPD is not OCD. OCPD is about this intense preoccupation with orderliness, perfectionism, and control.
To the point where it gets in the way, loses flexibility.
Precisely. At the expense of flexibility, openness, efficiency, they might be workaholics, neglecting leisure or relationships. difficulty discarding things.
But they don't have the true obsessions and compulsions like in OCD.
Correct. And importantly, with OCPD, the traits are often egosyntonic.
Meaning they don't see it as a problem themselves?
Often no. They might see their way as the right way, unlike someone with OCD who is usually very distressed by their obsessions and compulsions.
Okay, so that's a good overview of the clusters and disorders. How does all this knowledge translate into the nursing process? What do students need to focus on when caring for these individuals?
Assessment is step one, always, and it needs to be comprehensive.
Meaning?
You need a thorough psychosocial history, life experiences, relationships, how they cope. You need to explore their developmental background, early life, key relationships, and really look at their patterns in relationships now.
And specifically assessing for things like manipulation, aggression.
Yes, assess for potential manipulation, aggression, that fear of abandonment we talked about, impulsivity, things that directly impact the care environment and safety.
Okay, so based on that assessment, what kind of nursing diagnoses might pop up?
Well, several could be relevant. For BPD, risk for self-mutilation is a major one.
Right.
Impaired social interaction is common across many of them, given the relationship difficulties. Defensive coping often fits.
And for antisocial, maybe risk for other directed violence.
That could certainly be relevant depending on the assessment. And underlying a lot of these, you might find chronic low self-esteem.
So in planning care, what are we aiming for? What are good patient outcomes?
We want to focus on helping them develop healthier ways to manage. So outcomes like verbalizing feelings appropriately instead of acting out, demonstrating better coping skills under stress.
Engaging in positive, goal-directed behaviors.
Yes. And crucially, refraining from manipulation or self-harm, reducing those maladaptive behaviors.
Okay, let's get practical. Nursing interventions. What are the key strategies students should really take away?
Number one, a consistent team approach. Cannot stress that enough.
To prevent that splitting.
Exactly. Minimize the chances of staff being played against each other. Also, clear, consistent boundaries and consequences for behavior that crosses the line.
Providing structure and predictability.
Yes. And encouraging reality testing, helping them see situations more objectively. Working on problem-solving skills to manage those intense emotions or distorted thoughts.
Promoting responsibility is key too, right? Not letting them just blame others.
Absolutely. Accountability for their actions.
Yep.
Sometimes behavior contracts can be useful tools, especially around safety and self-injury.
And providing support, obviously, but...
Maintaining objectivity. Offer emotional support, build trust. But nurses need to stay objective to avoid getting caught up in manipulation or having their own emotional reactions, countertransference interfere with care.
Right, that's a tricky balance. What about treatments beyond direct nursing care? What else is typically involved?
Psychotherapy is really the main long-term treatment. Different types can work. Long-term interpersonal therapy, focusing on relationships. CBT, cognitive behavioral therapy, is common, targets negative thoughts and behaviors. And DBT, dialectical behavior therapy.
That one comes up a lot with BPD.
Yes, DBT has shown really good effectiveness for borderline personality disorder. It teaches specific skills, mindfulness, distress tolerance, emotion regulation, interpersonal effectiveness. Really practical skill.
And group therapy.
Group therapy can be great too. Good place to work on social skills, get support, learn from peers facing similar issues.
Okay, let's talk meds. This is always a big question area. What's the role of pharmacology?
This is super important to clarify. The sources are clear. There are no specific medications that cure personality disorders, period.
Okay. So what are they used for?
They're used to manage specific symptoms that cause distress or impairment. It's symptom-focused.
Like using SSRIs for mood or anxiety.
Exactly. SSRIs might help with mood, anxiety, maybe some impulsivity. Antipsychotics could be used carefully for severe thought disturbances or aggression.
And mood stabilizers.
Mood stabilizers like lithium or some anticonvulsants might help with that intense emotional lability or impulsivity you see, particularly in cluster B. But again, it's about managing symptoms to help the person function better and engage in therapy.
That distinction is so vital for students. Okay, final points. As nurses start their careers, what are some maybe special considerations when working with this population?
I think one of the biggest is remembering that many of these disorders are egosyntonic.
Meaning the person doesn't see their behavior as the problem.
Right. They might not recognize that their way of thinking or behaving is the issue. That can be tough for caregivers. But understanding it helps build empathy and avoid just getting frustrated.
And the stigma, it's still pretty significant, isn't it? Especially around BPD.
Unfortunately, yes, there's a lot of stigma. So, as nurses, it's absolutely critical to practice with empathy, treat every individual with respect, and consciously avoid those judgmental labels. These are complex conditions rooted in a lot of pain and distress.
So education for staff is really non-negotiable.
Absolutely essential. Ongoing staff education helps build those therapeutic alliances, helps staff manage their own reactions that counter transference, and ultimately leads to more consistent, effective, and compassionate care.
Okay, so bringing this all together, this deep dive really underscores that personality disorders are complex, they're enduring patterns, and they need a nuanced, consistent nursing approach.
Yeah, it's about understanding the specific traits, using that nursing process effectively, assessment, diagnosis, planning, intervention, and using evidence-based strategies.
Remembering those key interventions, clear boundaries, teamwork to prevent splitting, focusing on symptoms.
And using meds appropriately for symptoms, not as a cure.
And maybe the biggest thing running through all of this is the need for empathy and fighting that stigma.
Which really leads to a final thought for you, our listeners, especially you nursing students. Thinking about all this, how will really understanding these complex patterns change how you provide care? How will it help you be more effective and maybe more importantly, more compassionate?
Yeah, reflect on the challenges, definitely, but also the huge rewards that can come from helping people navigate these really difficult experiences.
Keep learning, keep exploring the specific disorders and treatments you'll encounter. It's a challenging area, but incredibly important work.